All right, good afternoon, everyone. We hope that you've been having a great weekend so far. My name is Rita Gupta. I'm a grade 12 student, and I am president of the Project Pulse Winnipeg executive team this year. So Project Pulse is a nonprofit youth-led organization, and our goal is to familiarize high school students with the field of the health sciences. In the past, this came in the form of an annual in-person day-long conference. But with the emergence of the pandemic last year, Project Pulse Winnipeg switched seamlessly to an online platform, continuing to bring students events, resources, and opportunities for health sciences education. All of the executive team roles are filled with passionate and hardworking students from diverse cultural and academic communities in Winnipeg. And they're also in the audience, so maybe give us a quick wave. Thanks, folks. All these roles contribute significantly to Project Pulse Winnipeg in unique ways and helped plan the professional panel today. So today, our Professional Relations Director, Vicky, will be hosting this event. On behalf of the team, I'd like to extend a warm welcome to our audience, which consists of numerous high school and post-secondary students from all over the province. So we encourage everyone to have their cameras on for the best experience of engaging with the panelists, but it is not a requirement. Please note that this event will be recorded and that the recording will be posted on Project Pulse Winnipeg's online platforms. This includes social media and our website. Please fill out and return the waiver attached to the email you received to confirm your consent to be recorded and posted as a part of this video. If we do not have your permission to feature you, you do not need to turn on your camera, and you are welcome to engage through the chat function instead. So without further ado, I will hand this off to Vicky to introduce herself and today's distinguished guests. Off to you, Vicky.
Thank you, Ria. So good afternoon, everyone. My name is Vicky, and I'm a grade 12 student. So I'm the Professional Relations Director this year, and I am so excited to introduce you to our first Project Pulse panel for 2021 to 2022. So when we think about types of doctors, I'm sure many of us think of like surgeons, radiologists, physicians, etc. But we might not think about pathologists, as this field is not as known as the types I've listed before. However, they should not be put aside, as they play an important role in the healthcare field as they provide diagnosis, which the clinicians depend on to improve the patient's health. So they're basically the heroes behind the scenes and often are called a doctor's doctor. So before I begin introducing our esteemed panelists for today, we would like to give a fair warning that autopsy photos will be shown. And they're not too gory, but if you're easily disturbed by these types of photos, we will provide more warnings later so you will know when they're coming. So with that, I'm excited to begin our introductions, and I'll begin them with Dr. Gabor Fischer. So Dr. Fischer is a department head at the Department of Pathology, Rady Faculty of Health Sciences, University of Manitoba, and the medical director of anatomical pathology at Shared Health Manitoba. He's a certified anatomical pathologist and cytopathologist. Dr. Fischer is the chair of the Canadian Society of Cytopathology, and also a member of the Royal College Committee on Specialties. Dr. Fischer has been active in volunteer pathology projects to improve the diagnostic, educational, and clinical services in low-income countries, including Vietnam, Liberia, Cambodia, and Peru, which is incredibly inspiring. Next, we have Dr. Jason Morin. So Dr. Morin is a forensic pathologist working as part of a team of forensic pathologists at the Health Sciences Center in St. Boniface Hospital. He also has dual appointments as medical examiner with the Office of the Chief Medical Examiner and as a clinical assistant professor with the University of Manitoba. And in addition, Dr. Morin is the Regents representative on the Specialty Committee for Forensic Pathology for the Royal College of Physicians and Surgeons of Canada. And he completed an undergraduate degree at the University of Manitoba in human physiology, followed by a medical degree at the University of Calgary. He then went on to complete a residency in anatomical pathology at the University of British Columbia and a fellowship in forensic pathology at the Office of the Medical Investigator in Albuquerque, New Mexico, through the University of New Mexico. And outside of his work life, Dr. Morin is an avid video game enthusiast and enjoys cooking and spending time with his family. And last but definitely not least, we have Dr. Yong Jia. So Dr. Tia completed the MD degree at West China Medical School. Then she came to Canada to obtain a master's degree in human nutritional science at the University of Manitoba. After that, she worked as a pathology assistant in Edmonton before residency. And currently, Dr. Tia is the fourth year anatomical pathology resident at the U of M. And her past experiences in pathology and research is definitely an asset to her residency training. In addition, Dr. Tia is the chief resident, who, along with her colleague, the senior resident, takes the administration role and hosts clinical pathologic correlation rounds, which definitely seems like a really important role with lots of responsibilities attached to it. So with all of those introductions done, with that, I'd like to hand it off to our wonderful panelists to begin their discussions. And after the discussion period, we will have time for the pre-prepared questions and also for the audience to ask live questions through the chat function. So I'm going to hand it off to our wonderful panelists to begin their discussions now.
Okay, thank you, Vicky. So I think I'm going to start. Just can someone confirm me that you guys can see the screen and the full slide view? Good, thank you, Jason. So first of all, thank you very much for inviting us. It's a great opportunity for us. Thank you for reaching out. We all feel that pathology is an under-recognized and an underappreciated specialty in medicine. However, it's a very cool and a fascinating discipline, and just a wonderful career. So we will try to explain what pathology is about today, and the format that we decided on. I'm going to give you a brief overview on pathology, how you can get into pathology, and why I think pathology is a really good choice if you are interested in science or if you're interested in medicine. Then our resident Yong is going to describe the duties and the daily routines of the pathology residents. And she can give you a different perspectives on how the residents see pathology or why she was attracted to pathology. And actually, I'm not sure who is second or who is third. And Dr. Morin is going to give you an overview in one of the coolest specialties, if not the coolest specialty in medicine, in forensic pathology. So that would be the route. We all prepared a few slides, but we came here with the intent of an interactive session. So whatever questions on or comments or anything you want to bring up here with us, we are more than happy to discuss it. So what is pathology? So it's really a diagnostic specialty in medicine. So as Vicky mentioned in the introduction, most people would know what a family practitioner does, what a surgeon does, or maybe what an internist does, or maybe even a radiologist does in their daily workload and daily routine. Very few people will tell you what a pathologist does and what actually pathologist's role in medicine. If I really want to summarize it, it's pathology is based on some analysis of cells and tissues, and at least in most of the specialties, not all of them. And most of the jobs, the pathologist jobs, are office-based. So it's not a job when you spend your day in the operating room. It's not a job when you spend your day in clinics or walk-in clinics. And it's not a job when you spend your day on hospital wards. You really mostly spend your day in an office. In most specialties, the overwhelming majority of the specialties, probably all of them, you have a microscope. And most of your daily workload is centered around the microscopic part. Again, in most specialties, not in all of them. One of the questions you guys prepared for us is why it's called the doctor's doctor. And I think the easiest explanation is if a patient goes to a doctor because there are some symptoms, there are some problems, there are some concerns, we go to a doctor to help us and tell us what's wrong with us. So the patient would go to a doctor for an answer. For the doctor, many times, actually needs a pathologist to get the final answer, because many times additional procedures, lab tests, biopsies, surgical excisions are needed to tell the patients what's wrong with them. So the doctor would ask another doctor to give an opinion, and that other doctor would be the pathologist. So the doctors help the patients, and the pathologists help the other doctors to get the final answer. And this is one of the beauties of pathology. The pathologists are the final decision makers in many patients' journeys. So if there is a, let's say if there is a lump in one of the patient's breast, and we want to know whether it's a benign lesion, in those cases, there is really nothing to worry about. They may not even need a surgery, or there is a breast cancer. The only way to tell that, and the only way to make a final diagnosis, is to do a biopsy and send that biopsy to a pathologist. And the pathologist under the microscope would examine the tissue and would make the final diagnosis. And based on that diagnosis, the clinical team would either go to one direction, the lesion is benign and there is nothing else needed to be done, or it's malignant and the patient needs surgery, many times radiation or even chemotherapy. So this is what would happen. It's demonstrated. The pathologist's role is demonstrated here to a patient's journey. So this is a laparoscopic appendectomy. The appendix would be removed. It put in formalin in some containers. The containers are sent to the lab, and you see in the front of the picture these cassettes. So the specimen would be accessioned, and it would be grossed by a pathologist assistant. Those are individuals who are helping our work. They would describe these specimens, they would measure the lesions, they would give a good description from them, they will section them, and they will put the most important parts of the specimens into a cassette. Then it would be processed like this. Then it's covered, it's put in formalin. Formalin is a fixative, which prevents the tissue from degradation and saves the tissue in a very good shape for a long time. Then it goes through certain processing and staining steps. And the end of this technical journey is really the slides, the glass slides, which you can see in the right lower corners. Those are the pathology slides. Those would go under the microscope, and the pathologist would make a diagnosis based on those. So the route to be a pathologist, I am not the best person to give you an advice how to get into med school, since I did my med school in Europe, and the European education system is very different from the North American one. But maybe Jason can give you some advice on that later down the road. I can tell you that after medical school, if you are still interested in pathology, you go through a matching process. The matching process is essentially a scenario when the medical students at the end of the training would identify and would rank the disciplines and the programs they would like to get into. And the programs would also rank the applicants, and this matching algorithm would select and assign the residents to residency programs. So if you're interested in pathology, through this process, you have to pick pathology programs. And after the match, let's say you are matched into a pathology program, then you would complete your residency. And after residency, you would go through, in most cases, further subspecialization. You can do a fellowship, or you can go to an area of focus competence program. One of the questions you guys forwarded to us is, what is fellowship? Fellowship is an additional training year or two years after completion of residency. So with the completion of residency, you would be a pathologist, but let's say in Jason's case, you would not be a forensic pathologist. For that, you call yourself a forensic pathologist, a cytopathologist, or a breast pathologist, or gastrointestinal pathologist. You have to add another year or two in your training and complete these fellowships or area of focus competence trainings and go through them. And many of them, at the end of it, there would be an exam requirement. So after the medical school, those are the specialties listed that are related to pathology that can be selected for medical students: anatomical pathology, general pathology, neuropathology, hematological pathology, and medical microbiology. One way or the other, they are all related to pathology. So after residency, you have to select which one you would go for. The most popular one would be anatomical pathology. Probably 90–95% of the residents who are interested in pathology would end up in anatomical pathology. General pathology, anatomical pathology, if I want to oversimplify this, is the specialty that would make the diagnosis based on the surgical samples, which I showed you, or the cytology samples. Forensic pathology would also be part of anatomical pathology. General pathology is a little broader, and general pathologists would do a lot more instrument-based lab tests, hematology, biochemistry, some analyzers or microbiology diagnosis. Neuropathology exclusively focuses on brain and brain pathology and central nervous system, and also muscle is included there. Hematological pathology focuses on blood and lymph nodes and bone marrow and the disorders of those. And microbiology is really a science and a discipline about microorganisms. After residency, again, you would go through some additional training to get further subspecialization in forensic pathology, cytopathology, molecular pathology, which is a really important and growing field. Or you can get specialization in breast, skin, lung, gastrointestinal, gynecologic pathology, or whatever interests you. My own path, my medical school, I actually completed a PhD program in medical biochemistry. I wasn't sure whether I wanted to be a researcher or a diagnostician or a clinician. I enjoyed my years in a PhD and I learned a lot there, but I also learned that I don't want to spend the rest of my life in research. So I came back to the clinical side of medicine, and I applied to a residency program. I get into a general pathology program. And after completing that residency, I had 2 fellowships, one in oncologic pathology. So that was a year entirely focused on tumor and tumor pathology. And I also had another year in cytopathology. So what do the pathologists do on a daily basis? So the most important part of the job is the clinical service. So that's the diagnostic work. When you would get your samples, you would get those glass slides I showed you. You would put them under the microscope and you would make a diagnosis based on them. You also have to do some consultations, either to your clinical colleagues or to another pathologist. If I have a really difficult case and I'm not sure about the answer, or I have a favored diagnosis, but I need a confirmation, I would go to another pathologist for another opinion. We have a lot of interactions with other specialties, radiologists, surgeons, and oncologists, and that's also part of the daily workload, either through some rounds and meetings or just phone or email conversations. So that's clinical service. If you end up in a tertiary center or in a bigger center, and most jobs are in these centers, you will also have an opportunity to participate in education and research. In education, you can teach medical students and residents, or sometimes even graduate students. And in research, you can either build your own research lab, although that's a really demanding and a very difficult path, or you can collaborate with other specialists, and you can be a member of a multidisciplinary research team. You can also participate in administration, leadership, and you can do some patient advocacy. One of the interesting questions you forwarded to us is how COVID-19 impacted the daily routine of pathologists. So I can tell you that pathology was one of the luckiest specialties during the pandemic, because our daily routine really it was not impacted as much as many of our clinical colleagues, not even close. But the clinical colleagues, they had a totally different practice. They couldn't see patients for a long time. And then virtual visits took over the in-person visits. Surgeries were postponed. Biopsies were postponed. Cancer screening protocols and procedures and visits were postponed. It was a dramatically different practice compared to pre-COVID. During COVID, the pathologists essentially still did the same job. They went into their offices. The number of the samples decreased on the surgical pathology side, not on the forensic pathology side, but definitely on the surgical pathology side. And since we don't have a daily interaction with patients, our job really didn't change that much. One of the cool things about pathology is really at the forefront of technical advances and developments. You probably know about many of the innovative technologies in medicine. I just wrote a few of them here. As you know, in these days, you can measure your blood pressure with your smartphone if you buy a small device for that. You can also measure your blood glucose level with your smartphone, and there are nice apps to actually monitor your blood sugar and give you some graphs about the last month or the last 12 months or the last 2 years. Or maybe you can harmonize the data with some other apps you have on your phone, how much exercise you do, and so on and so forth. You can do an EKG. You can even do an ultrasound now, and devices relatively easily attached to the iPhone. So the medicine, every single specialty in medicine is changing along those lines, and technology is taking over, and it's bringing us some really new and sometimes revolutionary solutions to problems we didn't know what to do with in the past. So this is one pathologist. She's actually the department head in Toronto, Rita Kendall, who's a bone pathologist, and one of her projects and studies is a three-dimensional printer and a three-dimensional printing technique replacing joints in patients who either had a fracture or some developmental abnormality or some other disease, and they don't have a joint, they don't have some cartilage, or there is some mechanical structural defect in the joint. And Dr. Kendall is working on a project when this could be replaced in a bio-friendly material through a 3D technique. Another interesting thing is digital pathology. So this is the glass slide on the left side here. And as I told you, we are examining as of today these slides with the traditional microscope, which is up here. But the landscape is changing, and digital pathology is going to take over the role of the traditional microscope. So you can also scan these glass slides, and you can review the slides on your own monitor rather than on your microscope. So I think probably by the time any of you would be pathologists, you can do most of your job even on your iPhone or on an iPad or some really decent computer. The digital pathology is an important tool in diagnosis, also a really important tool in teaching, as you can see on the right side. This is from the University of Leeds. This is one of the centers implemented digital pathology relatively early, and they take full advantage of this. And they move their educational platforms in med school to an entirely digital system. So you can see a digital power wall here, and you can see the teacher standing in front of that wall and explaining the histologic features to the students. And in the left side, that would be a pathologist station. We call it a cockpit. It's really similar to the pilot's cockpit in the airplanes. And through all these monitors, we can see a really good image and resolution of histologic pictures, and you can make a diagnosis relatively easily. You can consult colleagues with this digital method, as I told you, even by using an iPad, as you can see it here, or you can build three-dimensional images from tissues, as you can see here. Those are images built from kidney slides. So it's a fascinating and really, really interesting part of pathology. So why should you choose pathology? For me, one of the biggest advantages is that intellectually it's a challenging specialty. It's not a boring field. And I don't want to be offensive to many of my clinical fields, but many of them, my friends, would actually tell me that after a while, they find their job a bit boring, a bit repetitive, and probably they burn out earlier than the pathologist. But I get my case mix every day. There's almost at least a few cases that would require some intellectual detective work to put the diagnosis together. They are unusual. They challenge me. I either need a consultation or some additional workup to get to the right diagnosis. I have to see the radiologic image and the clinician's impression to make that diagnosis. And I really enjoy that. So this is not a boring field. It keeps you challenged every single day. And I think that's important. It has a really good life-work balance, and that's also important. Most of your weekends would be free. You rarely have to work after hours, and even during work hours, if you work in anatomical pathology and you are not scheduled to do frozen sections on day, you can design your own schedule in a really flexible way. This is not true for many of the clinical specialties. If you have a day on clinic, you have to stay at the clinic from 9 to 5. If you are scheduled in the OR, there is no way you can reschedule or move your surgery if something comes up. Pathology is different in that sense. There's a lot more flexibility and a much better good life-work balance. We also have a generous compensation as pathologists, so we are very happy with our salaries. We have a high job satisfaction rate, and most studies would show you that the pathologist job satisfaction rate is higher than most of the clinical fields job satisfaction rate. We are exposed and we can use and take advantage of advanced technology, digitalization, anything coming in computers, artificial intelligence. It's really interesting in pathology. It has an absolutely major role in personalized medicine. When somebody has a tumor, the specific mutation needs to be found or targeted to specific drugs. You need a pathologist, you need a molecular pathologist to tell the oncologist, hey, I have this mutation here, and you can use your special drug to treat this patient there. That answer also comes from the pathologist. There are multiple career options within the field. As we went through, there is clinical service, there is education, there is research. And even in the clinical field, you can find your favorite organ system you want to specialize on, breast or lung or brain or whatever else would interest you. Is it the right fit for you? Well, it's really the only person who knows the answer is you. So we have to find this out. I would invite all of you to come and see what we are doing. You can have some visits, even some virtual visits or career days or mentorship programs, and we can tell you more about pathology. You can set up observerships or you can participate in some summer projects, scientific projects, research projects, and you can read and ask and reach out. One of the most useful resources I found is this one, is the Inter-Society Council for Pathology Information. They have a really good brochure describing briefly what pathology is, the different branches in pathology, why pathology is interesting, why pathology is going to be really useful in the future, how you can learn more about pathology, and what other resources they recommend you to learn about pathology. So I will have this link and I can send it out to you, or if anyone wants a hard copy of this brochure, we can share those with you also. And that was Mark. Thank you very much. And I will stay until the end and we will answer some questions.
Okay, thank you, Dr. Fischer. And I think now I will, as a pathology resident, I will talk about what's our typical day like as a pathology resident. So first, just like any other doctors, our first and foremost job is to see our patients and treat them, right? And however, like Dr. Fischer mentioned, most of our job is office-based job. We are not going to the clinic or wards to see the patient face to face, but we are looking at slides. So that's our part to seeing patient and train patient. So that's our weapon, secret weapon, the microscope. And at the beginning of the introduction, Dr. Fischer mentioned we have those glass slides that hold tissue from patient. And we put the slides under microscope to observe and make our diagnosis. And here is a software system we use to write down all our diagnosis here. So this system kind of like a patient's chart. We put our diagnosis there. And later the day, we will bring all those slides with a tray to meet our attending pathologist. And we will sit down together and review the slides using something like this, multiple head, and attending will operate the microscope here, and from here I can see the image at the same time. And at this point, we can we might make the final diagnosis and put our final report into this system.
Yong, your slides are not advancing.
Oh, sorry. Let me.
Yeah, we are still on the first slide.
Oh,
That's okay.
Let me try again. Is still the title?
Yes.
How about now?
Do you have two screens, Yong?
No. Yes. Okay, now I have a little helper. My son is coming to help. Should I do it again?
Like this.
Just to share again? Resume. How about now?
Stop and reshare.
Okay,
Stop share.
let me stop share and
Screen. And then
this
there.
one?
No. There.
I-
No, the other.
this one. And
Now,
it's good
now,
now?
yeah, now you're on your second slide.
Okay. And oh, wait. How about
Yeah.
now?
Yeah, you're good,
Okay.
Yong.
So that's a microscope we mentioned. We are looking, we used to look at the slides, and that's a system I mentioned. We write down all our diagnosis here. And here is a multiple head microscope, which we are using together with our attending pathologist. We sit down together to look at the case and make the final diagnosis. And do you have the next slide? Okay, here I just want to show you some slides from our patient. I feel it's like quite magic, like pink, blue word under the microscope. So this slide is from a patient with tumor, and basically those little lumens are blood vessels. And here we notice that there is a cluster of tumor cells in the lumen, which it doesn't belong to. So it is not a good sign. It means the tumor will travel from the primary site to anywhere other place of the body with a blood flow and grow there. Medically, we call it a metastasis. So we will write down this into our final report and let other doctors treating this patient know this patient has this adverse prognostic pathologic features. And here is another slide from a young lady. The lady had a difficulty to breathe, and they take some biopsy from her lung. Here, upper is a normal lung tissue, supposed to be like a very clean, clear background with those air space there. But compared to this, we can see there are lots of blue inflammation and fibrosis within and between the air space. So now we can tell the clinician why this lady had such a difficulty to breathe. And sometimes the case is not very easy and straightforward to diagnosis. So when we have a difficult case, we need to do some extra work to figure out the final diagnosis. Just like clinicians, they order blood work or X-ray for the patient, we put our orders into this system, and we might need to get the we might need to get some extra stains, such as immunochemistry stain, or sometimes we even need some molecular studies to help us make the best final diagnosis. And in addition to looking at slides, as residents, we also do some other things. One of the big part is called grossing specimens. And don't get scared by the word grossing. I remember the first time when I talked this to my 5-year-old, and he said, "Oh, mommy, are you dealing with all those yucky stuff?" I said, "No." The grossing specimen doesn't mean the awful things you might find in the lab. But it's an act. Gross here is a verb. It's an act of the gross examination. It means the macroscopic examination of specimens. You need to describe the size, the shape, the color, and the consistency of the tissue. And it can provide critical diagnostic information through this examination. And after that, you will decide where to take the sections to demonstrate the lesion, the tumor, and this all together, it can provide information that is essential for diagnosis, and also provide some prognostic criteria. Like in this photo is one of our wonderful residents. She's grossing a breast specimen from a patient. She's carefully examining the tissue and decide which tissue she will take to submit for slides. And here are all the cassettes she will use. And some of the specimens are large, like this one. And sometimes the specimen just very small, tiny. This is a tiny mucosa from the patient's esophagus. And also we, as a resident, we will attend the frozen section procedure. What's that? It's a procedure allow pathologists to rapidly analyze and diagnose tissue while patient is still in the operating room. How this works? So during the operation, the tissue is transferred to the frozen section lab directly from the OR. There, the tissue is placed on a machine, freezing machine, where the tissue is frozen within seconds. And then a very thin slice of tissue is extracted from the frozen section, prepared on a slide and placed under the microscope for review. And after reviewing the sample, the pathologist will communicate the results with the surgeon in the operating room. Immediately, the surgeon can adjust the operation accordingly and avoid unnecessary reoperation. And also we attend multidisciplinary rounds, which is also called tumor board rounds. It's a meeting like with group of doctors such as pathologists, surgeons, and medical oncologists, radiation oncologist, sitting together to determine the best possible cancer treatment and a care plan for each individual patient. So during the conference, we will we will explain, we will do some like PowerPoint like this to explain, to further explain the patient's diagnosis. And sometimes we might also do some recommendations. For example, encourage clinician to repeat a biopsy if there is no enough tissue was taken, and explain how, from a pathologist point of view, the new biopsy sample should be obtained. Also, we can review the previous, if the patient had some previous biopsy, we can review the previous one with the current one together from the same patient, and help clinicians make the diagnosis or planning further treatment. And also, we can help the tumor board decide what additional treatment the patient might need, such as radiation therapy or chemotherapy. So I think it's a really interesting part as a pathologist resident, in my personal view. And also, as a resident, we also need to learn. So we attend academic half day, which happens once a week during the academic year. And it's a protected time. We will sit down to have some lectures from pathologists, organ system by organ system, and learn the more in-depth knowledge about each organs. And as a resident, we also get involved teaching. We were teaching medical students who are interested or want to know more about pathology. And we also teach residents from other departments like internal medicine, surgery, oncology, and teach them some more like very basic or some pathology knowledge related to their field. And lastly, like Dr. Fischer mentioned, we also get involved into different research work. We can do some research incorporate with other with clinicians or researchers from other fields, and do some research work. And that's all from me, and I will pass it to Dr. Morin.
All right, thanks, Yong. So as Vicky introduced me at the beginning, I'm a forensic pathologist working predominantly out of the Health Sciences Center. So I thought I'd come and share some of what I do with you guys. I'm the person that Vicky made the disclaimer for at the beginning. So in my presentation, I have some pictures, predominantly just of organs from autopsies, just showing some pathology, and they are gross in the sense that they are, you know, something that most people aren't used to seeing every day, but they're there predominantly for an educational purpose in this case. So how do you get to become a forensic pathologist? Well, Gabor went over his path previously, and my path wouldn't be much different than that. Most people, before they enter medical school, will start off with a university degree of some kind. It doesn't have to necessarily be a science degree. There's certainly a lot of medical students that are out there that have an arts background or, say, an engineering background. And really, to get into medical school, there's just prerequisite courses that you need to have taken. So you can take those courses in the context of a let's say, biological sciences degree. But the vast majority of people are going to do some sort of biological sciences. Let me just move this. Once you get into medical school, most medical schools will be 4 years, although some medical schools in Canada you can do in 3 years instead of 4. After that, as Gabor explained, you'll have some sort of match where you'll get matched to a residency program. And so you would enter anatomical pathology if you wanted to be a forensic pathologist. That's a 5-year residency. And then after that, you would do a fellowship. So a fellowship is, like Gabor was saying, a 1 or 2 year kind of fellowship where you do some sort of specialized training in whatever you want to do. So people that come out of the anatomical pathology residency and go on to do, say, a fellowship in surgical pathology will become surgical pathologists in whatever organ system you can imagine, versus as a forensic pathologist, my specialty is the autopsy. It doesn't mean I'm not looking at things under the microscope, but a lot of my job is still looking at things under the microscope. But I do a lot more of that gross pathology that Yong was talking about. So I look at a lot of things just with my eyes and then follow up with some microscopic. So when I'm doing an autopsy, kind of the biggest thing that's being asked of me is to determine why someone's died. And so in the medical sense, we call that the cause of death. And so that's the event or the entity that is ultimately responsible for someone to have died. So it could be a single event, so something that happens suddenly and someone dies from it. It could be something that happens and then sets off a chain reaction of multiple other things happening. And so in that sense, it doesn't necessarily have to be temporally related with death. It can be something that happens and then maybe a couple days or even a year, years later, someone dies from it. Or it could be just multiple things all coming together to cause someone to die. Cause of death reports, and say my report, are mainly a document that's used for vital statistics. And so when I determine a cause of death, all of that determinations of everyone that's died in a year gets put into a pool of how people have died. And then the government has a bunch of money that they're going to spend on things like preventative medicine. And so they're going to pull data from why people have died to see where they should be spending that money effectively. When we're coming up with the reason why someone's died, just like other areas of medicine, it really is an opinion-based practice. It's me doing an autopsy, putting everything together and saying what I think the most likely cause of death is. And so you can imagine rarely, maybe there's a difference of opinion that happens in there. But for the most part, most people would agree on why someone's died. Along with cause of death, there's also a concept of manner of death, which is also something that we're determining when we're doing an autopsy. And really the manner of death is just kind of a general description of why someone's died. Kind of if we were to put the death into like a box, what box would we put that death into? And in general, there's 5 categories: a natural death, so someone that's died of natural diseases; an accidental death, so someone that's died because of something extrinsic to their body. So a good example of that might be a car accident where someone has injuries from their car accident and they've died from them. A homicidal manner of death, which I mean, I'm sure everyone intrinsically understands. Someone's done something specifically to someone else that's caused them to die. Suicidal deaths, so again, someone's done something to themselves that's caused them to die. And then undetermined, that just means we don't know what category it fits into. And often when something's undetermined, it's because we don't know why they've died. And so their cause of death is undetermined. And because of that, their manner of death is also undetermined. If you live in New York, there's actually a 6th manner of death, and it's called therapeutic complications. And so sometimes people die secondary to medical procedures, and those medical procedures are usually, when someone's dying secondary to a medical procedure, it's because they have a really, really significant natural disease that they need a really big medical procedure to solve. And those big medical procedures can sometimes be dangerous. And so you get into this weird dynamic of, is that an accidental death because, I mean, they've died extrinsic to a medical procedure, or is it a natural death because they needed that medical procedure because of their natural disease? And so New York said they didn't want to deal with that anymore, so they made this therapeutic complication section. Disclaimer, this is where some of the gross pictures start. And so when we're dealing with natural manners of death, I mean, often that's the common everyday manners, natural disease processes. So this here is a heart. Cut and cross section. So this is the left ventricle of a heart. This is the right ventricle of the heart. And this here is a coronary artery cut and cross section. So these are the arteries that supply blood to the heart. And so when those coronary arteries get blocked, people have heart attacks. And so people can die from those heart attacks. And this is someone that because of their heart attack, has weakened their muscle of their wall, and they've ruptured their wall, and they've bled out from that rupture of their wall. So we get the common kind of disease processes that people have died in the natural deaths. And then sometimes we get the very uncommon reasons for people to have died. And so this is a 55-year-old man that presented to the hospital, and he wasn't able to really quite tell the doctors when he presented to hospital what was going on. He didn't feel right. And so he was getting investigated at the hospital, as you do when you go to a hospital. They'll draw some blood and run some tests and see if they can find anything wrong. And while that was all going on, he suddenly went unresponsive and he died. And the nurse who was looking after him at the time specifically described him as going white, starting at the top of his head and then going down to his body. And so instead of his normal pink kind of red color, he just suddenly went really pale and white. And so when I did the autopsy, I found that his stomach was completely filled with blood. And so that's why he was going white, is because he was losing a lot of blood. And so what happened in him on this side of the picture here is his aorta. So the aorta is your major blood vessel that leaves your heart and carries all the blood to the rest of your body. And then right next to certain places in the aorta is where your bowel sits. So this is his small bowel right here specifically. In his aorta, he had what's called an aneurysm. So this kind of rounded area that we see here is an aneurysm. So that's an outpouching in the vessel itself. And so in this case, he's got some sort of weakening in the wall of his vessel, and it's created that outpouching because of the weakening. In him, that weakening was because he has just standard atherosclerotic disease. So as we get older, we get plaque buildup in our arteries, and he had a lot of plaque buildup, and there was an inflammatory response to that plaque buildup, and that inflammation caused irritation in the bowel that was right next to it. And so eventually the irritation caused them to stick together, and eventually a tract formed between the two because of that inflammation. And so all the blood that would normally be in his aorta is now into his GI system, which is essentially the outside of your body. So that's why he died. Now, we go from the natural deaths in forensic pathology all the way to the unnatural deaths as well. So I do a lot of autopsies in the context of people that have died in suspicious circumstances as well. So we work with police to investigate those deaths. And so this is an X-ray from someone that was shot multiple times. So we can see the skeletal system itself, skull, the spine, the ribs, the arms, and all these really dense white things on the X-ray are all bullets that are left in this person's body. So he's been shot multiple times. In the locations of where they are, they're kind of in the region of the chest cavity. So it would be a safe assumption that the bullets have gone through the chest cavity and hit something important, and because of that, they've died. You can imagine in cases like this, I'm not so much really, people aren't really asking me so much what the cause of death is. People pretty much know that already. They know someone was alive and they got shot multiple times and then they were dead. Ergo, the gunshot wounds is probably why they died. In this case, I'm more here for documentation, because at some point someone might be going to court with charges because they've killed this person, and I'm going to go to the court and provide some evidence in relation to that. It's important to remember, though, that I'm also a doctor, just like all the other pathologists that have talked today are also doctors. And so part of that isn't just becoming a robot that figures out why people die. I mean, I'm also a doctor that treats patients in the same way that Gabor and Yong treat patients, to help kind of come together and provide, as part of a healthcare team, provide good care for people. And so this is actually an autopsy of an infant, a 4-month-old infant that unfortunately died at home. And prior to dying, she had evidence of her heart failing. And so this is her heart. And if we look at the wall of her heart, we can see from here to here, it's this dark brown color. And from here to here, it's a little lighter brown color. And so this area here is what we would call a spongy heart. And so this baby, when it was being formed in utero, the genetic signals that normally tell the heart to become a solid muscle mass didn't happen in this baby. And so this is what we call a non-compaction cardiomyopathy. It's just a fancy way of saying that the heart muscle didn't form properly. And because it didn't form properly, it didn't have enough strength to beat all the blood through the heart. And so this baby went into heart failure and it died. So I figured out why the baby died, but non-compaction cardiomyopathy is an inherited disease. And so this is a disease that has a specific genetic abnormality with it. And this 4-month-old also has a 2-year-old sister. And the 2-year-old sister has the same genetic abnormality. And so now that family knows about it, and the 2-year-old sister can be treated before anything bad happens to her. So we do all this with an autopsy. So what is an autopsy? Well, an autopsy is really just a very in-depth examination of someone after they have died. And so there's 5 major components. The first one is some sort of information before the autopsy. So before we even look at a body, we kind of get an idea of the medical history or the circumstances surrounding why they've died. It gives us some expectations on maybe what we'll find during the autopsy. We do an external examination, so it's exactly what it sounds like. We're looking at the outside of the body for things like demographic information and identification type information, but also for things such as injuries that might explain why someone died. We do an internal examination where, again, we're going to open up the body and we're going to look at everything in detail inside the body, so all the organ systems and things like that. And while we're doing that internal examination, I'm going to take small pieces of tissue and make slides from them, just like Gabor and Yong do in the context of tumors. And then I might also grab some materials like some blood, for example, that I can run what we call ancillary tests on. So I might want to do some toxicology to see what drugs might be in someone's system around the time they die. At some point after that, I'm going to get all those materials I've made from the autopsy and I'm going to review them. So I'm going to review the microscopic sections, any results from ancillary tests, what my thoughts are in the context of the circumstances of death. And then I'm going to make a report based on that. And that report is going to give my opinion on why someone died. And so those 5 major components, all autopsies follow those same principles. It doesn't matter if someone's died in the hospital and it's a hospital-based autopsy, if someone's died suddenly and unexpectedly in the community from a natural disease, let's say like a heart attack, or if someone's died in a homicidal manner, so that person that had the multiple gunshot wounds, we would follow this same flow chart, so to speak. So for me, what does my typical day look like? Well, for the most part, I'm doing autopsies in the morning, I'm doing reports in the afternoon. So in general, that's my day. But interspersed with that, there'll be times when I have to go to court or attend meetings in regards to going to court. So in those homicidal type manner of deaths, those suspicious cases, often I'm required to go to court to present my findings to help a jury understand why someone died and provide some context to the rest of the case. I do some teaching with medical students, residents at the university. I'm on multiple committees. For instance, the subcommittee that Vicky was talking about before is a committee in charge of designing how forensic pathology is taught to residents in fellowship programs. I have duties at the Office of the Chief Medical Examiner as a medical examiner. And then there's multiple departmental meetings that we go to, as well as family meetings where, again, I meet with families and discuss the results of autopsies. So again, they can understand better what's going on. Now we move on to the questions portion.
Yes, so thank you so much to Dr. Morin, Dr. Fischer, and Dr. Jia for all of your really enlightening discussions. So we're first going to go over the questions that we had pre-prepared. So these are the questions that the audience members asked when they registered. And if anyone in the audience has any questions right now, they can always use the chat function to ask those questions. So our first question is from a grade 9 student who asks, how did you choose this field of study? And what sparked your interest in pathology to pick it over other fields of study you might have been interested in if you had any? So anybody can answer this question?
I mean, for me, when you get into medicine, often there's kind of a point where you have to choose whether or not you're more interested in treating patients or diagnosing patients. And so pathology is one of the specialties that fits under that diagnostic umbrella. And for me, I preferred that because it's kind of that problem solving of medicine where you're kind of trying to figure out what's wrong with someone. And for me, I wasn't as interested in the treatment of patients because for me, once you know what something's wrong, well, if someone has this disease, usually you just give them this treatment. And so it's very formulaic at that point. So for me, that's what I liked about pathology. And I mean, once you decide, if you decide you wanted to go into a diagnostic specialty, I mean, pathology isn't the only option. I mean, radiology would be a good example as well. So often, once you choose a diagnostic specialty, you kind of think about the medium you want to work with in that diagnostic specialty. I mean, for pathology, it's working with tissue and microscopes versus radiology is working with computers and x-rays and things like that.
Yeah, I agree with Dr. Morin. I think I'm kind of like same. When I was like in medical school, I think always quite fascinating just to like working with those slides, like solve the puzzles and you put all the clues together and find the final answers. I think it's quite fascinating.
Yeah, I agree with my colleagues. To me, the most attractive part was this intellectual investigative work that you do with your brain in pathology. And just like Jason said, in the clinical side, many times you have an answer. You really what you do is just follow an algorithm how you treat your patients, and it's not the case of the diagnostic side of the medicine. So for me, that was the most attractive part, and also still the most rewarding part of being a pathologist.
Thank you. So our next question is from a grade 11 student who asks, how was the process of going through university to become involved in pathology? And do you have any advice for any students interested in pathology and or the health sciences?
I would defer this to Jason. As I told you, as I went through the med school in Europe, and that's a very different system to what we have here in North America. So maybe his personal experience or reflections would be the most helpful for the group.
Yeah, I mean, it's a difficult question to answer because it kind of balances on two things. I mean, medical school, I don't want to say it's difficult to get into medical school, but I mean, certainly there's limited spots and a lot of people want to get into medical school. So there certainly is some competition to getting into medical school. And so there's one track of thinking of gearing your, say, university experience towards getting into medical school, which is fine. There's nothing wrong with that. And certainly you're giving yourself a background in university to help you in medical school that way as well. For me, though, I think you should do what you like to do. You should do what you want to do and be passionate about what you do. And so there's kind of that, do I do means to an ends to get into medical school to do what I want to do? Or do I just start doing what I want to do and work my way towards getting into medicine? So I don't think there's a right or a wrong way in that sense. I mean, getting into medical school is really just it's really just a check mark kind of checkbox kind of thing where they're looking at your grades, they're looking at your extracurricular activities, they're looking at your MCAT score. So for people that don't know, there's a standardized test that you take when applying to medical schools, and so they're taking all that and looking at it and then kind of ranking you against everyone else that's applied that year. And so there's no magic to doing that. You kind of know already just by looking at the application process, kind of those markers you have to hit to get into medical school. The problem with that, though, is because there's so many applicants that everyone's kind of the same. Everyone's kind of in this big pool because they've all done those same things that everyone needs to do to get into medical school. So while you prepare for that, I mean, think about the things that kind of make you more interesting, the things that make you stand out a little bit more, and embrace those things as far as your cultivation of going towards medicine.
Yeah, that definitely makes lots of sense. Okay, so our next question is from a grade 12 student who asks, what is the most interesting diagnosis you have come across over your years?
Maybe I will share one, maybe not the most, I don't know. It's a simple one, but I think it's quite fascinating. I remember when I was a resident and just grossing a very simple appendix. I said, oh, appendix, easy peasy, and cross-sectioned and put into cassette. And I didn't pay much attention to the appendix tip. But turned out there's a teeny tiny tumor in the appendix tip. We call it carcinoid tumor. It's a small benign tumor. It's quite often at the appendix tip. But when I look back, and if I did pay more attention, you might notice that there is a small yellow nodule in the appendix. And so my point is, like, as a pathologist, you need to pay attention to details from the beginning, even like from like when you are grossing. And once you pay attention to all the details, and can lead you to the right path.
Yeah, for me, it's maybe the most memorable story. It's not actually related to the diagnosis. It's related to the patient journey. So one day I got an email from a Canadian person who was working for the United Nations and was stationed in Europe, in Bosnia, and his wife developed the breast lump and was worked up for breast tumor, actually not in Bosnia but in Serbia, and they said that they need our help because for some ancillary studies, for some studies that would be required for chemotherapy and further therapy for the patient, those studies cannot be done in the hospital they have access to. So they asked us to do an ER/PR and the HER2 test on the breast cancer. So I told them, sure, we would do it. Just please send over the blocks. So we would look at the case again, and we would do the ancillary studies, and we would call the oncologist and the clinician. So by the time you got home from your service, with a few weeks, everything will be ready for your treatment. And they send over the blocks and they send over the cases, and they came over from Europe to Canada in a couple of weeks, and they came to my office. So we reviewed the slides with my colleagues together, and it turns out that the patient didn't have breast cancer. So the original diagnosis in Serbia, because they didn't have access to some of the immunohistochemical stains we did, and they couldn't run some studies we were able to do, those actually ruled out carcinoma in this woman. So I will never forget that joy and relief I have seen on her face and her husband's face when they were in my office, and that all the stress they had to deal with in the last 3 or 4 months, it was just gone in an afternoon because they learned the news that she actually doesn't have cancer. So that's probably the most memorable diagnosis.
I mean, I have a lot of weird stories just because of what I do, some of which probably aren't appropriate to share in this setting. But I mean, one of the neat cases I had was someone that was shot one time, and the bullet went into the chest and then into the heart. And we were doing the autopsy, and one of the first things we do when we do an autopsy is we open up the to access the insides, and we draw some blood from the femoral vein, and that's the blood that we'll use eventually for, say, toxicological testing or any kind of testing we would want to do. And so the femoral vein is I guess, iliac femoral vein kind of sits low down in the pelvis. And so we opened it up, we went to go draw some blood, and there was a bullet within the actual femoral vein itself. And it was an odd place. There was no gunshot wound anywhere else. We did the rest of the autopsy, and the only gunshot wound was the one that went into the chest and then into the heart. But the bullet went into the heart, but didn't exit the heart. And so on scene, they had tried to give this person CPR to resuscitate them. And while they were giving them CPR, they pushed the bullet into the venous system and then all the way through the body with the CPR down into the femoral vein. So it was just a weird circumstance.
Wow, that sounds really interesting. and all of your other examples definitely really put into account of how important it is to be a pathologist. Okay, so our next question is also from a grade 12 student, and it is, what was the most difficult decision you had to make, and what was a challenge you faced, along with how you managed to overcome this challenge in your career?
I mean, I think for a lot of us, especially people at Yong's position, is we struggle with what we want to do for the rest of our lives. And I mean, it's a plug for pathology in the sense that pathology you can almost think of like internal medicine, in the sense that you can pick any organ system and you can be a pathologist in that organ system. And so you kind of get to the end of your residency and you have like an entire plethora of choice ahead of you to decide what you want to do. And sometimes that can be a little bit difficult to narrow down, because it's not very often that you get to the end of your residency and you're like, I like this and nothing else. Because you probably have liked a lot of things as you've gone through. And some of those things are probably things that you didn't think you would like or were even on your radar. I mean, I work with a lot of, I always knew I wanted to do forensic pathology just because of who I am and what I like to do. But I work with a lot of residents that it's not even on their radar, and they kind of think it's gross to begin with, and then they actually start doing it, and then they've gone on to be forensic pathologists. So, I mean, I think that kind of decision point, both as you get to the end of your medicine degree, where you have to choose what residency what you want to do, and again, the whole world's open to you. And then again, at the end of a lot of residencies, not just pathology, you kind of have to choose where you want to subspecialize again, if you want to subspecialize. And I think that's a difficult choice, because you're always left with the what ifs. You know, if I do this, well, what am I missing if I don't go into this? So, I mean, I don't know that that's the most difficult choice I've had to make, but it's what I could think of at the spot.
Yeah, I agree. On my own journey is, I think the most difficult thing is, because when you are in medical school, there are just so many interesting things. It's really difficult to choose. But at the end of the day, you have to pick your one residency, or at least a couple you would feel really comfortable with. And that comes at that stage with some anxiety and some difficulties. Am I going to miss the other ones? Am I going to be happy in the specialty? Is it really for me? So that's difficult. And for me, it was a similar decision-making point when I was asked to take on some leadership roles. And from that point on, your life changes, or you want, or your career. So you won't spend your entire day as a staff pathologist, and you won't just diagnose in your office. You have to take on other responsibilities, and some of that leadership role is really enjoyable and good, but other parts of it are really, really difficult. And that was a similar difficulty for me. I don't regret I did it, but that's a difficult call to make, whether you're going to be comfortable in a new role or not. So those are the two most important but most difficult decisions for me.
Yeah, I can share one maybe a little bit different, because as Vicky's introduction, I did my medical school back in China. And actually after graduation, I did some pathology training there in China. And then because of some family reasons, we immigrated to Canada. And at that time, I had to give up pathology. I think it was a really difficult decision for me. And like we kind of like gave up everything and start from the beginning. And then fortunately, when I came to Canada, I find a job related to pathology. I was doing pathologist assistant, start to grow thing, and had a new opportunity to get into the system. And then it's another difficult decision. I need to do all the exams from the beginning again. But I'm so happy. I think I feel so lucky, and I made my decision to start from the beginning. And yeah, that's my little bit sharing.
Yes, thank you so much. Everything you guys said was very inspiring. So that was our last question. And if anyone in the audience has any more questions that we couldn't get to with the timing that we have, feel free to forward it to the email that you got the Zoom link from, and we'll forward it to the panelists so we can answer your questions. So with our first professional panel now coming to a close, on behalf of Project Pulse Winnipeg, we would like to send our sincerest thanks to all of our amazing panelists for taking the time out of their busy schedules and sharing their insights, experiences, and answering all of the audience's questions. Your expertise in your field and your experiences brings forth a very, very inspiring discussion with our audience. And in addition to our wonderful panelists, we would like to extend our heartfelt thanks to the audience members. Thank you for making this event a success by registering to attend. And moreover, thank you to those who took the time to think of an insightful question that stimulated a great conversation. All of you are the reason why Project Pulse is inspired to continue to create online events. So thank you very, very much to the audience and also to the panelists.
I am super proud of this executive team, and I can't imagine myself working with a greater group of people. So I look forward to what Project Pulse Winnipeg will plan next. Looking ahead, we recommend that you follow us on Instagram and Facebook to stay up to date on when our upcoming events are happening and how you can get involved with the organization. And our website is also a good place to find more information about Project Pulse Winnipeg and access links to these panel recordings. So with that said, we hope to see all of you again next time. Take care and have a very good evening. Bye.
Thank you for the invitation. Thank you, guys.
Thank you guys for inviting us.
Thank you for being here. Bye, everyone.